Greetings. I'm Dr. Ajoy Shetty, consultant spine surgeon at Ortho Hospital, Coimbatore. This video is going to demonstrate the indications, the technique of anterior odontoid screw fixation, which is a motion preserving surgery done for type 2 odontoid fractures. Patient is a 25-year-old male who presented to us 3 weeks following a road traffic accident with neck pain and restricted neck movements. His neurology was normal. As you can see in this lateral radiographs, you can identify the fracture if you are very carefully looking at it. But however, majority of these situations, a patient who comes to us with an upper neck injury, what is much more important is to get a open mouth view and a CT scan. Open mouth view clearly delineates the type 2 odontoid fracture, shows the normal relationship of the C1 C2 passage joint. This can be well appreciated in a CT scan, which shows the normal relationship between the C1 and the C2. There is no anterior subluxation, which rules out an unstable C1 ring fracture. And the coronal cut, which shows the type 2 odontoid with the normal relationship of the C1 C2 joint. Sometimes you may see the avulsion of the transverse ligament, which would be a relative contraindication for this procedure. MRIs basically may not have much significant role, but it may show a disruption of the transverse ligament sometimes. In a normal neurology patient, the role of MRI is usually very limited. You know the classical description by Anderson D. Alonso, the classification of type 1, type 2 and type 3. Type 1 and 3 are usually can be treated conservatively, whereas the type 2 is the one which most commonly needs a surgical stabilization. You know the type 2 is further classified into 2A, 2B and 2C. 2A and 2B are ideal candidates to do a odontoid screw fixation, but the fracture pattern of 2C is a contraindication. Therefore, 2A, that is a transverse fracture, and the posterior oblique 2B are usually an indication for anterior odontoid screw fixation. Having said that, we should also remember that there are other contraindications which are very important. One is the presence of a different fracture pattern, that is a type 2C, associated injury of the transverse atlantal ligament, associated C1 joints injury, and most importantly the technical skill of the surgeon. It's also important to be sure to understand that the body habitus, if somebody with a short neck, the emphysematous chest is a contraindication. Chronic non-unions and also definitely you should not try this procedure. The first important step once your surgery is planned is the positioning of the patient, like how you do a classical anterior cervical discectomy. And the most important thing is to have a clear area of angulation from the chest to the C2. By extending the neck, by flexing the neck depending upon the fracture pattern, and probably also if necessary you can give a traction, usually with a Mayfield, if not necessary a Mayfield, a Gardner valve tongs, you can give a traction and then you can achieve the reduction. What is very important is to get good radiographs. It's better to use two C-arms perpendicular to each other to get a good lateral view. Be sure that the fracture is reduced. Get a good open mouth view, that is very important. You should be able to appreciate the odontoid very clearly, and this should be the position of the C-arm. To aid to get an open mouth view, you can use cork, you can use a retromolar placement of a gauze, or you can use the bronchoscope assisting device which helps to keep the mouth open, so that you can visualize the odontoid screws quite well in an open mouth view. It's important that you first place a K-wire outside, which is starting to the base of the C2, and where it touches the skin, a margin or this thing, you can mark the transverse incision. which usually comes at the level of the C5, C6. Your incision could be either horizontal or vertical. I mean, vertical usually it makes the your control of the instruments much easier. Horizontal is cosmetically better. You make a small incision extending from the anterior margin of the sternocleidomastoid to just up to the midline. Then is a classical anterior Smith-Robinson's approach. You cut the platysma, you get the plane medial to the sternocleidomastoid, and then feel for the carotid pulse and try to go, and you have to be medial to the carotid. Therefore, that is the carotid sheet on the left side and the tracheoesophageal on the other side. Use the cannulated sleeve, then guide it slowly to the base of the C2. As you can see here, the cannulated sleeve is positioned to the junction of the C2 base, which is between the anterior cortex and the inferior cortex. But it's always ideal to get an entry point slightly behind this, so that there will be a good anterior cortex, so that when you're tightening the screw it doesn't breach. And if you find it difficult, you can shave the superior part of the C3 so that your entry point is just posterior to the junction between the anterior cortex and the inferior cortex. Keeping that in position, you advance a guide wire which comes with each instrumentation set by using C-arm continuously both in lateral and AP view. But here, if you are observing, once you are using the instrumentation and pushing, there could be a loss of reduction. Therefore, it's important that you constantly monitor the position of the odontoid while you are doing the procedure. Just because, and here we have used a technique wherein a gauze piece in an artery forceps is passed through the open mouth and we are pushing the C1 back so that we are achieving a reduction. This is one of the techniques which is very, very useful to achieve an intraoperative reduction, especially when it gets displaced when you are doing the procedure. The guide wire is then advanced both in lateral and AP view to the tip of the odontoid. Be very careful that it does not cross across the odontoid, because next will be the junction of the medulla and this can have a serious consequences. You measure the size, the length by using the measurement devices, and then you have to use a power instrument to drill across over the cannulated instrument. But as you can see in the circle around there, your assistant has to hold the guide wire throughout so that when you are drilling it doesn't migrate across. Okay, that's very, very important step. This holding of the guide wire when you are drilling forward and also while removing is very, very crucial. While drilling forward, it prevents the forward passage of the guide wire. While you are withdrawing, it prevents the backing out of the guide wire. As you can see in the AP view, the guide wire is passed to an adequate distance. And we have found it's always better that you use your hand to derotate it anti-clockwise rather than using the power instrument. If you use a power instrument, there is a more likely chance the guide wire may back out. And I would say this is one of the most important crucial steps. The most important step I would say is to achieve reduction, able to get a good image in the image intensifier. Therefore, be sure that the guide wire are straight, it is not bent. You've got options of using cancellous screw, which is be ideal so that you can get a lag effect across the fracture. And once you have drilled it, the same precautions should be maintained throughout the procedure. The guide wire should not move in forward rather than, and also should not move backward. Assistant will be holding the guide wire throughout the part of the procedure where you are going to do the tapping, drilling, and also while introducing screws. the screw is of a proper size is measured. But having said that, these screws are not commonly used, and therefore most of the time we tend not to have adequate size screws. Be sure you are able to achieve the compression across. In the end, you get a good compression across the fracture site, and the AP and the lateral position wise, it looks quite satisfactory. And this is well seen in the post-operative radiographs. The fracture is well fixed, the alignment is well maintained in the lateral view. How to avoid complication is be sure you get a proper entry point. If the patient is elderly osteoporotic, it's better to be under the inferior lip rather than being at the point. It's better to have a bicortical purchase, but unfortunately for that you need a screw of adequate length, otherwise loosening is possible. The screw also should not be long. If there is a failure of the anterior odontoid screw because of inadequate fixation, the best thing is to not to do anything for the screw. Go ahead and do a posterior C1 C2 fixation. Post-operative course includes mobilization, which starts on day 1 at the same day. We can use a collar for about 4 to 6 weeks and normal neck movements after a period of around 6 weeks to 2 months time. Thank you very much.